Thank you, and good morning, ladies and gentlemen. Thank you to the organizers for inviting me to this conference. I've really learned a lot, and it's been a lot of fun. My charge is to talk about what we're calling here the Ponseti X technique for neglected or recurrent clubfoot. These are my disclosures. Elizarov taught us that there are two ways to address the foot. One is correction through joints, and the other is correction through bones. So my charge is to talk about the correction through joints, i.e. soft tissue distraction, not osteotomies. How does it work? Well, this is an artistic diagram showing a clubfoot that's being distracted by an external fixator. And so what happens, I think, is that we create space between these small bones. And then how do these small bones grow? The midfoot bones don't have growth plates. They grow centripetally. So if you hold it long enough, they grow and fill these spaces. At least that's the theory. I'm not sure anyone's ever proven this. Maybe this needs to be proven with MRIs. But this is the theory anyway. And it kind of makes me wonder how that will happen if we're getting the frames off. And Anatoly said he got his soft tissue frames off in 45 days. So I'm not sure 45 days is enough time to do this, although if you maintain it with a cast, maybe that will allow the centripetal growth of the midfoot bones. There's been a literature, mostly from about 20 years ago when this started to become popular. This is Bradish's article. These are distraction, soft tissue distraction, no osteotomies, 17 feet, 8 excellent results, not amazing. This is from Inho Choi in Seoul. He had arthrogrypotic feet, they're pretty bad. 12 feet and 11 excellent results, or grade 1 results. Gamal Hosni in Egypt described 25 feet and 11 were good. And out of Brazil, this article where they had 38 feet and 30 out of 38 had a complete correction and no pain, all through soft tissue distraction. But there are complications that can occur with these techniques. This is fasciolysis. We know in clubfoot there's an old adage that says the soft tissues are hard and the hard tissues are soft. So when you distract these feet, sometimes what happens is instead of distracting the joint, you distract the growth plate. So you have to be careful about this. I have an answer for it, which I'll show you. And this is the typical clubfoot frame that has been used in many of these papers. There's a hindfoot ring with 3 distractors. There's a forefoot ring with a medial and lateral distractor, and you can have also additional puller uppers on the forefoot ring. The problem is that as we got into the Ponseti method, Ponseti taught us that rotation was really important. You have to externally rotate the foot. You have to abduct the calcaneus. And so my question is, where is the rotational correction here? You're not really doing anything that's applying a rotational vector. Ponseti taught us about this abduction, that you have counter pressure with your thumb on the neck of the talus and forefoot abduction with your other finger. And so you are externally rotating, what he referred to as calcaneal abduction, but I call it external rotation. So that seems to be important, and the calcaneus has to be free to rotate. Well, I'd like to credit my good friend, our former fellow, colleague, and esteemed editor of the JLLR, Milan Chowdhury, who in 2002 introduced me to the concept of applying Ponseti principles to the clubfoot external frame correction. And we just heard Milan's talk, and this was my interpretation after hearing Milan. And this is what Milan looked like 20 years ago and what I looked like, this is about 18 years ago. This is my interpretation of Milan's frame. This is after we've done some of the supination correction, but what we're showing here is the red arrow is showing the rod that's distracting on the medial side and pushing the forefoot into valgus, or pushing it and externally rotating the forefoot. And the all-important Taylor neck wire is the yellow arrow. It's cut off on the lateral side, but on the medial side it comes out and is attached to the tibial ring, just like your hand would hold the talus on the tibia and with your thumb blocking the talus. So Milan taught me this, and I tried a few, but these are very unstable frames. They're not really connected very much, and the patients found them uncomfortable. So I kind of wrestled with that. And at the same time, we started using lots of these Hexapod frames. And the Hexapod, if nothing else, is a rotation machine. It's very difficult to make a rotational construct with the classic Elizarov. There are ways. You make the merry-go-round, but it's not easy to do that, especially in a complex foot frame. but with these Hexapod style frames, you can easily do rotation. So this was what Ponseti taught us. You have to externally rotate these feet, and why not do it with a Hexapod style frame? So this is the solution that I came up with, and we'll go through what the principles are. But the foot is rotating externally, and the thumb that's blocking the talus is this, this talar neck wire, which is an olive from the lateral side, and it's attached by these paddle plates to the tibial ring. So that's your hand that's blocking the talus, and the other hand is rotating the foot out. Potential indications for this X-Fix treatment in relapsed clubfoot: age 2 to adult. 2 is my youngest. I'll show you an adult patient as well. Previously operated feet that you don't want to go back and operate through someone else's scar, and very stiff teratologic feet. I will preface this, and this is highlighted in yellow. You should always try casting first. And I've learned this from my former fellows, especially Monica Nogueira, who treated kids up to age 12, 13, 14 in Brazil and got very good results with casting alone. So always, always, always try casting first. Here's a 3-year-old girl with a relapsed clubfoot. She's had a posterior release. I did Ponseti, and then I did a posterior release, and now she's relapsed. What do? I don't want to go back through my old scar. There's my old scar. I don't want to go through that again because I've been there once before. And one of my other partners, Janet Conway, taught me the rule: don't treat failed plan A with plan A. So what are we going to do? So this is the solution. We apply a very simple frame. The foot frame is 2 calcaneal counterposed wires, olive wires, and a midfoot wire, a 4-foot wire with an olive on the medial side. That's your foot ring. And then the red arrow is showing you the talar neck wire. That's your thumb, your Ponseti thumb blocking the talus. And then there's one other wire I've added, and that's the yellow wire. The yellow wire is through the distal epiphysis, and the purpose of that is to protect it from fasciolysis. During the distraction, and when you do all these, you're also adding some distraction. You're not just rotating, you're not just dorsiflexing, you're also distracting. And the importance of that is that it's really I call this a supercast or an anti-cast. When we do casting, we crush joints. We're compressing the ankle, we're compressing the subtalar joint for trying to dorsiflex. But when we do it with an external fixator, we're distracting the joints. We're decompressing the cartilage surfaces while we're dorsiflexing. So I call it supercast because it's a smart cast. It's able to distract the joint while it dorsiflexes. So we don't crush the talus, we don't get as much talar flattening, I've even seen from excessive casting a growth rest of the distal tibia. So this is the frame as it's put together. The yellow wire is what Millen taught me, to have a talar neck wire to block the talus. And while we're doing this rotation part, we want that wire attached to the tibial ring. When we start to dorsiflex, then we want to detach it from there and attach it instead to the foot ring. The other wire is the red wire. It's a stirrup wire. It's not tensioned. That's the wire that's in the distal tibial epiphysis that's preventing it from being distracted, and it focuses the forces on the ankle joint, not on the distal physis. This is after 2 weeks of rotation. So the first program, you just program in rotation and correction of any varus that's present. So if you have heel varus and rotation, that can all be corrected. This is occurring through the subtalar joint, and when you program this rotation, you're also programming in about 5 or 6 or 7 millimeters of distraction as well. You don't want to crush joints. Once you finish the rotation, then at that point you have to do something. You have to modify the frame. You have to take that talar neck wire and detach it from the paddle plates and attach it to the foot ring. And why are you doing that? Because now you want to dorsiflex, and if you want to dorsiflex, you want the talus to be able to move freely, not constrained by that wire. So now that wire now becomes part of the foot frame. How do you do this? Well, with most kids, you do it in the operating room. It's a trip back to the OR. With neuromusculars or myelos, you can do it oftentimes in the clinic. It depends on the child, but it's not a terribly difficult modification to do. You leave the wires long, uncurl it, and don't take the tension off. Attach it to the foot ring, and once it's attached to the foot ring and tensioned, then you can remove the 2 paddle plates. So with certain kids, you can do it in the office. And then I talked about that wire in the epiphysis. That's to prevent this complication. So that wire doesn't change. That's the The red wire is the epiphyseal wire. The yellow wire has now been detached from the paddle plates and attached to the foot ring, and this is at the end of dorsiflexion. So it's a Ponseti sequence. In Ponseti, you do external rotation abduction, and then you do a tenotomy and dorsiflexion. So we're trying to recapitulate the Ponseti sequence. And this is our very happy little girl with her externally rotated foot after it's dorsiflexed. And this is her pre-op x-ray. Did I have a wire in the calcaneus? Yeah, there's 2 wires in the calcaneus. There's counterpose. So the foot ring is counterposed to olives in the calcaneus and a first metatarsal to fifth metatarsal wire. So it's 3 wires in the foot plus the talus. This is what she looks like in follow-up. That's her pre-op picture in the upper left. And then maximum dorsiflexion, not amazing, but I think sufficient, and plantar flexion. This is her external rotation, what her foot looks like, and what she looks like with a valgus heel, plantar-grade foot. This is a younger girl. Now, why would I operate on such a little girl like this, a 21-month-old? The problem is this girl has had surgery. She's had a PMR. What are you going to do when you get a relapse? Now, I know what to do now, because this is an old case. What I would do now is I would try the Ponseti again, because Monica has shown me that even in cases, and not just Monica, but also Dr. A from Portugal has shown me that you can take previously operated club feet, Anna A, and you can do a Ponseti method and maybe even stretch scar. Not a guarantee, but it's always worth a try. I don't remember in this girl if I tried to recast her or not, but I certainly don't want to go back and operate through someone else's scar. That's not my incision, that's someone else's. This is what her x-rays look like, and a little bit big frames for a little girl, but it's still doable. And we did her bilateral, same simultaneous, because she's small enough that parents can pick her up and move her around. And this is her result with the frames off. So she's got nice dorsiflexion, nicely corrected feet, plantar flexion. This is her external rotation, post-op, standing pictures. So not bad. And I didn't have to do anything other than put a bunch of wires in. Now, there are some cases where you have a very significant cavus or forefoot adductus, and for that, I recommend what I call the Ponseti 2 frame. It's where you cut the rings, modify the forefoot, and convert it to a classic circular non-hexapod style frame. So this is what we do. This is something I do in the operating room. So if I want to correct the forefoot adductus, and this is deviating a little bit maybe from the Ponseti principles, and note the foot wires. I'm a big fan of foot wires. The toe wires, rather. So what you do is you cut a segment out of the lateral ring, and you make a single cut in the medial side of the foot ring. So now the foot ring is 2 separate rings. If you think you're going to do this, you have to carefully plan where you're going to put your wires, because on the lateral side, you need to actually remove a piece out. And this is what it looks like after you've done some distraction. This is after the foot's corrected. And so you see how much distraction is taking place on the medial side and how much separation has taken place on the medial side of the ring. That medial side of the ring did not have a piece cut out, it just had a cut. So that's all distraction through the midfoot joints, sorry. So we reviewed 22 feet and 17 patients. There was a mixture of idiopathic, arthrogrypotic, et cetera. And the mean time in frame for us was 3.5 months. Residual equinus occurred in 1. All others achieved full correction. There were some superficial pin infections. The conclusion that, and this is one of Mark Edelman's cases, he was a contributor to that series. This is a before and after. That it's a safe procedure, doesn't require open surgery, minimizes scarring, and therefore does not burn any bridges. You can always go back and do whatever else you want if this doesn't work. So here's just some diagrams to show you the correction, the initial correction of the varus. And you notice the paddle plates with that wire on the neck of the talus. And then you go back and remove, this is the sequence of removing the paddle plates. You first attach that wire to the foot ring and then remove the paddle plates. That way it stays tensioned. And then you do the third sequence, which is the dorsiflexion. And this is dorsiflexion to neutral with distraction. You're distracting the joint because you don't want to crush cartilage. And then beyond neutral, I recommend going up to 15 or 20 degrees because you always get some rebound. The soft tissues have myofibroblasts that remember where they were and they want to go back there. And I talked also about this, dividing the ring on the medial side, removing a piece of ring on the lateral side. This is what it looks like as you do the correction, and after that correction is completed. So not all feet need this, but if they do, that's an option. An alternate method of soft tissue correction is the Hexapod Mitre frame. This is a very powerful frame. A Mitre joint is just a 45-degree angle joint, and so that's what this is meant to look like, 45-degree angle joint. And this is a case from Scott Nelson in Haiti, and this obviously very, very severe feet, and yet with a Mitre frame, you can very gradually correct the hindfoot deformities and the forefoot deformities independently and gradually. So this is her before and after, and then she came back and had the second side done. That's how the Mitre frame looks before and after correction. And I'd just like to show you an adult in which we did this soft tissue correction. Now this is a special adult. This is not a clubfoot adult. This is an adult who has a neurologic clubfoot. He has a motor vehicle accident with a traumatic brain injury, multiple lower extremity fractures, compartment syndrome, and he's walking on, you can see he's in equinus, he's walking on his toe there. He's got an absolutely rigid foot that has no motion whatsoever. This is what he looks like. He had presumably an old compartment syndrome, varus, equinus. And so I apply a Mitre frame, and the assumption here is that the joint surfaces are normal. At one point, a minute before his accident, he had a normal foot. But now it's a normal foot that's just positioned abnormally by contractures of joints and tendons. So this is what the Mitre frame looks like. You notice that on the AP view, we're distracting the ankle joint. Always distract joints so you don't compress them. This is what it looks like clinically. And in this case, I didn't fix the toes, but I did have a toe plate that's protecting them. And I think we did flexor tenotomies. This is immediately after surgery, during the correction, at the end of correction. So at the end of correction, we've dorsiflexed at about 15 or 20 degrees because we anticipate some rebound. Pre-op, rigid equinus, had absolutely no motion. Post-op, some dorsiflexion within limits, and then follow-up, a standing view. So this is another powerful frame for doing corrections in the hindfoot and the forefoot and midfoot individually, forefoot correction, hindfoot correction. So some considerations when you're looking at feet like this. Where is this child? It's one thing if you can bring him here to Dallas, I mean, you have all your facilities, but what if you're in Haiti? What's your skill set? Do you have the ability to do this and the technology? And who's going to provide the follow-up? So luckily in Haiti, we have a good setup there where Scott Nelson, Francois Alexis is there, and we can do these kind of frames because we know they're going to get taken care of when we leave. Thank you very much.
Dr. Richards has a question. Thank you, John. Very nice, as always. With this technique, you're working on difficult feet. You get them nicely plantar grade. What impact has this technique had on your decision or need to perform subsequent tib-ant transfer?
So great question. So if I can rephrase your question, I'd say, it's one thing to get the correction, but what about, the subsequent surgeries to maintain it? And that's a very important principle. We have to obtain a correction and we have to maintain it because the factors that were making it bad are still there. So what I do is I will get the correction, overcorrect them, and then follow them very closely. And if at the first sign of any badness, I'll recast them and then book them for a tendon transfer to help maintain the correction. And I'm big into anterior tib transfer to the lateral cuneiform. And if there's any cavus element at all, I'll do a longus to brevis transfer as well. The problem, if you just do the anterior tib transfer, you are leaving the pronis longus as an unopposed pull into plantar flexion. And so I've seen a lot of kids in follow-up that have a very prominent first ray. So I often combine those two procedures. And then the other thing, if things get out of hand, you always have the option of doing bony fusions, but now you've got a foot that's reasonably corrected, and so it's not such a challenge to do a triple if you had to.
John, obviously great talk. I have a question about this inadvertent fasciolisis of the distal tibia. I recently had one trying to distract an ankle. And my question is, we've all had a few of these cases. Has anybody looked at future growth following this issue? Like, does it continue to grow or not?
Right, so the question is, if you get a spontaneous fasciolisis, does it go on to a growth arrest? And all I can say is, in my personal experience, the answer is no. And what I can also tell you is when it's happened to me, it hasn't happened since I started putting in the fascial wire, but it's kind of nice when it does happen because you can use it to get a little bit of, it's like your supramular osteotomy that Millen showed us. You kind of just use that, you correct through it. So I'm not dismayed when it happens because, it's a Salter 1, it shouldn't, low energy Salter 1, it should be fine. So I'm not worried about it causing a growth arrest.
But have you followed growth? Like, does it continue to grow?
Yeah, I mean,
Okay.
I've only had it once or twice that I can remember, and it was not a problem.
So can I ask a
It's
follow-up question?
obstacle.
So then why not, like in an older kid, do almost like instead of doing a supramalleolar extension osteotomy, do like almost an intentional fasciolisis controlled? It's closer to the cora.
Yeah, so it's a good point. I think if you were going to do it theoretically, you want to do tibia and fibula, and I'm not sure how to do that, how to create it both to happen. What I have done is use guided growth, and I'm not amazed with the results of that, but I put a little, 2-hole plate in the front of the ankle. Usually when I'm just trying to buy time until the kid gets older, and then SMO is an option.
Watch your heads.
Thank you very much. So we use the technique that we've copied that from you in Ireland, except we call it the Tayloretti because our kids don't like calling their frames a Ponset-Taylor frame. So we've just renamed it. But my question was on spina bifida. So are you using this a lot in spina bifida? So if you have a walking child with an insensate foot with a recurrent equinovarus and ulceration, is that something that you'd advise?
Yeah, so I've had a couple of spina bifs in my series, and I like them the best because you can do that modification in the clinic, 100%, because they don't feel any pain. Yeah. And so you can uncurl the wire and do all you want to do. So definitely myelos are good for this technique.
Thank you.
Thank you very much, Joan. The question is for you and for all the speakers. As pediatric orthopedic surgeons, we correct these in the kids. Till which age you keep following this, and what's happening to our patients which have been corrected, or we thought that we corrected them, and we don't know what's happening to the ankle joints, or what's the end results as adults. Do we have any outcomes about these cases?
Right. Great question. Just talking principles that motion is good, strength is good, and the more you can maintain motion and strength, the better your results are going to be. I like dorsiflexion. I'm not happy if someone just dorsiflexes to neutral. It's just simply not enough for activities of daily living. It's very important to point out that you need dorsiflexion to walk downstairs because your trailing leg has to lower you down. Kids who don't dorsiflex, they kind of bounce, and every bounce they're going down the stairs, they're causing impact on the cartilage of the joint. Amortize that over a lifetime, it's a lot of damage to the joint. So, I mean, Millen pointed it out, nothing destroys good results like good follow-up. And I'm sure that if I had longer follow-up on that series that I presented, that there'd be a fall off and a decay in the good results. Luckily for us, sometimes we graduate our patients and they become the problem of the adult foot and ankle surgeons. But I simply try to maintain as much joint mobility as possible. And in that regard, I'll just make one little plug for, I do a fair amount of posterior capsulotomies, and I know that if I say that out loud, there may be a lightning bolt, from Dr. Ponseti coming down and striking me, but I'm not happy with 0 degrees of dorsiflexion. So if I have just neutral dorsiflexion, I'll do a posterior capsulotomy. What I do differently than the old days, instead of casting them for 3 months like we did after the old posterior meter releases, I only cast them for 3 weeks, and I get them moving very quickly. And in most but not all cases, we were able to maintain motion after a posterior capsulotomy.
Yeah, John, thank you very much for this excellent presentation. I use your technique as well. It's working very nice. What are your hard arguments to decide whether to make the correction in the joint level, and when are you doing the osteotomies, and are you combining both?
Right, so Michael's asking a tough question. When do you graduate from, soft tissue correction through the joints to osteotomies? So the easy answer is after age 8. That's a general guideline. Kids younger than 8, they still have enough growth potential and enough remodeling potential, biologic plasticity that you can move, like that first picture I showed of how this whole system works of distracting the joints and getting centripetal growth to fill them. So over age 8, that's when I start to think about osteotomies, but I'll push it depends what the joints and the surfaces look like. If I think I can, I would prefer to do a correction through joints because it doesn't burn any bridges. Later on, if I have to, I can always go back and do a triple. And I remember very vividly when Ilazarov came to Baltimore to visit, we showed him a couple of cases where he had done distraction of feet, and we asked him the question, what do you do if you get a relapse? And his answer was triple arthrodesis. That's what he told us. So, Millen.
It's a very interesting question, and like the professor had asked before, over long term, when I see them, some of the club feet have come with a talus which doesn't have the offset in the neck. Yeah. And then when you try to get these up into the ankle, correct the equinus, and I've seen a few in the long term which have developed decreasing osteophytes in the lower tibia and the anterior talus. And I've even tried doing ankle joint distraction and removal of the osteophytes, like the footballer's ankle, with moderately pleasing results, not very satisfactory. So these are not, when they come to us at an older age, these are not normal, and sad to say that we can't make them perfectly normal. And they're bound to have some degree of limitations. Now, if one just looks back at the article, the long-term, the great article of Dr. Ponseti of the 40-year follow-up results, in which he compared the patients who walked into the ophthalmic OPD next adjacent to his clinic, and his Ponseti casted patients after 30 to 40 years, he found that a large percentage of the normal so-called population also had limitations of foot movements. So if you read between the lines, it's a process of aging, losing foot movements, movements in the ankle, movements in the subtalar joints. It's part of aging process. So it's really hard, and one should not really expect that you're going to give them fantastic, completely normal feet for a lifetime. But keeping them plantigrade mostly helps a great extent.
I know Ponseti, showed pictures of some of his patients doing a marathon. He had a video he showed of one of his patients running a marathon. Well, that's not been my experience. My experience is when these kids get older and heavier, a lot of them will complain of pain after football practice or pain after they've been on the basketball court. And I can only attribute it to the fact that they've got a smaller, stiffer, weaker foot. So I have a handout that I give my patients where I say, you can do whatever you want. If you want to play football or do track and field, long distance running, it's up to you. But if you ask me, my druthers are that you would avoid the high impact open chain kinetic exercises where you're pounding your feet. It's just my opinion. Because I've seen enough kids who, complain. And if I complain, I say, well, you modify your activity. That's God speaking to you, telling you that you're overdoing it.
Yeah, I have a comment on a couple challenges actually to post, because it's a very elegant way of doing things, but okay, this is really, really a craftsmanship level. So do you think how many people in the audience can repeat what you do with Ponset Hex? So I think we need to continue. First of all, it's not really following the principles of Ponseti. Again, we're working with X-Fix already not following. But actually, Milin's technique is much closer and more elegant than doing it. The problem is, of course, it's difficult to do with a frame. It's very time-consuming. Secondary, if you try to find it published, I can't. Yeah. So this is my first challenge. Can you really publish? And you have a journal actually where you
Yeah,
can
I
do
know a
whatever you
great
want.
journal where they'll
Yeah.
take it.
So
Guaranteed
why
they'll take
why
it.
can't you publish it? Because I actually learned first time from John when I went to Baltimore, of course, and he showed the slides from Millen, and then you can. And Ponseti-Taylor technique is not published good either. It's only one poster and one chapter. There is nothing anywhere else. But I think there's two things. First of all, you need to bring it to people so they can see. Not everyone will be using Hexapod. There is still a lot that can be done with traditional design. And then I think we need to optimize the technique so it can be a little bit closer to the Ponseti technique and still can be done with the Hexapod.
Right. Well, Jeff Young, who's in the audience, wrote a chapter, and it includes some of this stuff it's in Leonid Solomon's book, right? Yeah. So, but I'm also guilty for not publishing that. But we also, it's in our book on the TSF. Not allowed to say that. Not allowed to say PONSETYLOR. It's not CME friendly. So we wrestled with that. When we first came up with this technique, we had to figure out a name. So we called it it's a Ponseti, and we were using at the time the Taylor spatial frame. So we made a portmanteau PONSETYLOR. Portmanteau is a combination of two words like work and alcoholic is a workaholic, or breakfast and lunch is brunch. So we called it PONSETYLOR. But we decided that really wasn't CME friendly because it's actually a name of a commercial device. So we fooled around with different things and thought we'd maybe call it PONSETYLOR, Tailor, because it's tailor-made for the clubfoot. Or PONSETYLOS because we're rotating around the talus. But we ended up we decided finally it's Ponset X. So there you go.
That's excellent.
Okay.
Very creative. All right, we're going to wrap it up. Thank you, Dr.